Bronchiectasis phenotype and endotype, implication in disease management, Dr. Jalal Mohsinuddin, DTCD, FCPS, Pulmonology, Assistant Professor, Respiratory Medicine, National Institute of Diseases of Chest and Hospital. Introduction. Bronchiectasis is a heterogeneous disease. It is not a single disease entity, rather different etiologies lead to bronchiectasis through initial divergent molecular pathways, known as endotypes. Bronchiectasis is also phenotypically different due to different underlying mechanisms that results disparity in drug responses. Introduction. Continue. Improved understanding of the cellular immune, inflammatory, and microbiological pattern associated with clinical and radiological features of bronchiectasis has resulted in the recognition of important endotypes and phenotypes that will allow for personalized treatments to improve quality of life and outcomes of patients with bronchiectasis. Diagrammatic presentation of diversity of etiology, pathogenesis and clinical presentation of bronchiectasis, clinical phenotype by etiology. A. Allergic bronchopulmonary aspergillosis, ABPA. In allergic bronchopulmonary aspergillosis, ABPA, with bronchiectasis, treatments targets are fungal sensitization with corticosteroids, reducing Ig-mediated inflammation, and antifungal agents decreasing airway fungal load. B. In patients with antibody deficiency, immunoglobulin replacement therapy is given to correct the humoral defect and reduce sinopulmonary infections. C. Despite extensive assessment, a cause for bronchiectasis, idiopathic bronchiectasis remains a common diagnosis. In specialist centers which perform systematic diagnostic evaluations, the incidence of idiopathic bronchiectasis is much lower. Those with idiopathic bronchiectasis were more likely to have mild disease and not have chronic infection with P. aeruginosa. Patients with idiopathic bronchiectasis are more likely to be female non-smokers. D. Of the identified causes in specialist centers, post-infectious etiologies are the most common. Patients with post-infective bronchiectasis tend to occur in younger, e. COPD-associated bronchiectasis were more likely to have severe disease and chronic infection with Pseudomonas aeruginosa. Those with COPD tend to occur more commonly in older males with a smoking history. F. Bronchiectasis has also been found in patients with asthma, particularly those with uncontrolled, severe, or steroid-dependent asthma. Asthma-associated bronchiectasis is an interesting phenotype because in most cases the asthma is driven by eosinophilic inflammation rather than the neutrophilic inflammation most commonly seen in other etiologies of bronchiectasis. This is therefore beneficial to target eosinophilic inflammation in these patients. G. Bronchiectasis has been shown to occur de novo in hematological malignancies and the mortality in this case is high. Bronchiectasis in this group of patients is caused by acquired immunoglobulin deficiency and post-allograft stem cell transplantation. Clinical phenotype by associated microbiology. A. Chronic infection with P. aeruginosa. Chronic infection with P. aeruginosa has been shown to be an important driver of neutrophilic inflammation in bronchiectasis and has repeatedly been shown to be a phenotype associated with more severe disease, functional decline, frequent exacerbations and hospitalization, reduced quality of life, and decreased survival. Patients colonized with P. aeruginosa have 7-fold increased risk of hospital admissions and 3-fold increase in overall mortality, with 8% mortality at year 1 and 30 to 50% at 5 years. In cystic fibrosis, early eradication of P. aeruginosa is associated with improved outcomes such as reduced hospitalizations and lower rate of lung function decline. Failure of Pseudomonas aeruginosa eradication associated with increased frequency of exacerbations. B. Colonization with Haemophilus influenza. Colonization with Haemophilus influenza has also been shown to be associated with increased frequency of exacerbations of bronchiectasis but without the need for hospitalization. Mycobacteria, NTM. Nontuberculous mycobacteria, NTM, are isolated in patients with bronchiectasis with an estimated incidence of 2 to 14% with Mycobacterium avium complex, MAC. The Lady Windermere syndrome is associated with NTM infections in elderly, underweight women with middle lobe bronchiectasis. Clinical phenotype by symptoms. Symptoms are the expression of the etiology of bronchiectasis or complication. For example, those with asthma, COPD, or ABPA may have wheeze. Those with aspiration may report symptoms of gastroesophageal reflux disease, GERD. Although the main feature of bronchiectasis is a chronic productive, wet cough, patients do not always produce large volumes of phlegm. Some may produce phlegm only during exacerbations. This latter group of bronchiectasis patients has lower levels of systemic inflammation and is less likely to have chronic infection. They also have lower severity and improved clinical outcomes. Bronchiectasis patients who produce daily sputum are more likely to have high levels of inflammation. Disease severity. Clinical phenotype by exacerbation frequency. Exacerbations are important events in the natural history of bronchiectasis. They are episodes of disease deterioration and important markers of disease activity, in those who have frequent exacerbations having more active diseases. Poorer health status, worse quality of life, and increased mortality. Patients with chronic infection with P. aeruginosa have worse quality of life. Mortality is increased only in the group that has at least 2 exacerbations per year. Reduction in exacerbation frequency is therefore an important goal of bronchiectasis management. Interventions that have been shown to reduce exacerbation frequency are macrolides, inhaled antibiotics, and pulmonary rehabilitation. Radiological phenotypes, radiology imaging, especially HRCT scans of the chest, is paramount for the diagnosis of bronchiectasis. There are 3 predominant types of radiological patterns of bronchiectasis. In cylindrical bronchiectasis, the dilated bronchus has uniform caliber with lack of tapering of the distal airways. In varicose bronchiectasis, the dilated bronchus is not uniform and appears irregular and distorted. In cystic bronchiectasis, there is saccular dilatation of the bronchus with multiple saccular bronchi giving the appearance of cluster of cysts. A very common finding is a tree in bud pattern due to mucus plugging of the distal small airways or infective bronchiolitis. The distribution of bronchiectasis may also offer clues into the potential etiology. Central bronchiectasis is seen in ABPA. Tracheobronchomegaly, Mounier-Kuhn syndrome, upper and middle lobe predominant bronchiectasis is seen in cystic fibrosis, previous TB, and ABPA. Localized lobar bronchiectasis may be due to bronchial obstruction, E.G., foreign body, endobronchial TB, or cancer, previous lobar pneumonia. Aspiration, or Swyer-James syndrome, post-infectious bronchiolitis syndrome in childhood. Middle lobe bronchiectasis is often seen in Lady Windermere syndrome. Predominantly lower lobe bronchiectasis may be seen in primary ciliary dyskinesia, immunodeficiency, and alpha-1 antitrypsin deficiency. The finding of dextrocardia or situs inversus suggests PCD as a likely cause. Endotypes are subtypes of a disease defined by distinct pathophysiological mechanisms and may allow treatment to be directed at specific pathways. 1. A group has shown that the combinations of microbiome and proteome sputum analysis can distinguish between individuals with COPD and bronchiectasis versus those individuals with COPD without bronchiectasis. The researchers reported that principal component analysis identified 3 potential endotypes consisting of eosinophilic and epithelial-driven inflammation with elevated sputum levels of IL-5, IL-13, and GRO-alpha-3, systemic inflammation with elevated serum levels of GM-CF, IL-6. Vascular endothelial growth factor, IL-10, and IL-1-beta, 4, neutrophilic airway inflammation with elevated sputum levels of neutrophil extracellular traps, NETs, resistant, tumor necrosis factor, CXCL8, IL-10, matrix metallopeptidase 9, and elastase. Individuals with predominantly neutrophilic inflammation had more severe disease and were more likely to be treated with inhaled antibiotics. NETs were associated with increased bronchiectasis severity and chronic bacterial infection. Long-term macrolide treatment reduces NET, and this immunomodulatory effect is important in those with P. aeruginosa infection, and is a favored agent to reduce exacerbation frequency and sputum volume. Take-home message: bronchiectasis is a heterogeneous disease. Improved understanding of the endotypes, cellular immune, inflammatory patterns, and phenotype, microbiological pattern associated with clinical and radiological features of bronchiectasis has resulted to improved